Hello, this is Dr. Mustapha. I'm going to be sharing with you a unique case on endovascular CLI case with exo cross catheter utilization in a treatment of multiple level disease. This case study is unique in a way that this patient is 82-year-old, and we have to start to think about patients with this age group as patients that deserve the therapy that we deliver to them because they do have a normal lifestyle, and if we can give them quality of life, we should always attempt to do that. So this patient has breast pain with history of hypertension, hyperlipidemia, PAD, and also a patient has venous insufficiency. She was recently seen for follow-up with reports of new onset of breast pain and in the bilateral legs with numbness, coolness, and pain in the feet and ankles. So the ultrasound demonstrated bilateral disease, angiogram, and left intervention was performed, and patient was sent home. And then at follow-up, the patient had resolution of symptoms on the left leg, but now the right leg is symptomatic, so therefore, decision was made to pursue revascularization of the right lower extremity. The angiogram here is based on ultrasound-guided access in the proximal SFA. And you can see that the disease starts high up in SFA and involves the popliteal artery and distal SFA subtotal occlusion. And this is important to see that this could be problematic to cross. Never undermine calcific lesion that appears to have some flow in it. And as we go into the popliteal, especially when there's a knee replacement, again, this is something that you have to look into carefully to make sure that you don't miss anything behind the knee. The flow in the tibial arteries, if you notice, the flow in the tibial arteries is somewhat limited, and the anterior tibial artery does not appear to fill all the way, although a further selective angiography showed flow into the dorsalis pedis, but non-selective did not show flow into the dorsalis pedis. This is important to keep in mind because someone might decide and say that there's no flow into the foot. On the other hand, the flow in the foot is intact. So lesion crossing, in cases like this, you always start with a wire that you're comfortable with. And there are so many different wires that you can choose. You can start with a low gram tip wire with high torque ability, and then you can escalate that as you need to. In this case here, which was a low gram tip wire, we crossed. And if you notice, as soon as we crossed the lesion, we didn't IVUS immediately. And we've learned in the past, when you see a subtotally occluded vessel with some calcification in it, when you go to advanced IVUS, and the IVUS sometimes gets stuck, breaks, etc. So we tend to balloon these areas prior to further treatments. We're using here the exo catheter to go down and take a look at the different anatomical areas in the foot to decide whether a further evaluation or treatment of the posterior circulation or anterior circulation is needed. The exo catheter actually went down very smoothly all the way through the high-grade stenosis that is calcified in the SFA and popliteal, and went nicely all the way down into the pedal circulation. And this isn't shown very well, but it had no problem going into the pedal loop. So the exo catheter was very helpful in this scenario, which helped us do the selective angiograms that showed us intact dorsalis pedis, as well as arterial arteries and digital branches, and comparative flow from the ipsilateral AT injection. So keep in mind, the exo catheter here gave us comfort that the arterial artery and digital branches are intact. So another decision is, do we just go ahead and treat the inflow, which will give us this kind of results at the end, or do we treat anything further? To further assess this, we took a wire here, and in this case, we used a Xi'an black wire, and we put a double 90-degree angle on it. based on the angiogram we did with the exo. And so we left the exo catheter in place, and we used this wire, and we took it down to engage the pedal circulation. Just wanted to show you here the double angle degree on a Xi'an black wire allows you to actually manipulate it very nicely because it has a good torque in it. And you can take it nice away from branches like the AT and the perineal artery. So we're able to advance it down into the posterior circulation, and notice how the wire went into the lateral plantar and back into the medial plantar artery, which was not shown on the angiogram. So the dorsalis pedis artery that we saw earlier is intact, and now we're showing you here the exocatheter actually was able to go through the occluded plantar artery and also go in and go around the pedal loop of between the medial and lateral plantar artery. It's a unique feature that the exo delivered to us, which ensured to us that these are intact and present. So therefore, we can elect to treat them or not to treat them. This next step here is extremely important. Now, the angiogram did show high-grade stenosis. And now the question is, when you see something like this, what do you do with it? This IVUS image is a little bit intimidating when you first look at it, and it makes you think about what would be the best way to treat this. And we use this method where we mark the beginning of something like this. This is basically what we call a very high plaque burden disease. This is very concerning in terms of embolization, obstructive flow, dissections, flow limiting dissection, and complete obstruction of the flow in the artery. Notice the sort of speckles of calcium deposit in the fibrotic tissue, as well as the organized thrombus within this diseased area. This is probably a plaque that ruptured at one point and became organized. This is an area in the popliteal artery. Remember, we did not balloon anything distally. So this is probably one of the issues that this patient is dealing with, and that is a plaque rupture with embolization, which left a spontaneous dissection in the popliteal artery area. Now, this is the P3 segment of the popliteal, which looks reasonably healthy. So we don't have to address this at this point. And as we continue to go down toward the posterior tibial artery, notice the size of the posterior tibial artery is a reasonable size, but also notice the venous congestion, the venous size, and the multiple venous, tibial venous around the posterior tibial artery. The IVUS was taken all the way down into the plantar artery, but notice how small the plantar artery is here. Is consistent with a low flow state, number one. Number two, is there any significant disease, concentric disease that also involved here? Or is there an embolization that has happened when you look at this here? Was there an embolization that happened that obstructed the posterior tibial artery and the plantar artery? That is important to differentiate between all of them. Because of that, probably using laser would be a good idea because of the thrombus, organized thrombus, and also because of the possible embolized thrombi distally. So the idea to why using IVUS is because of the high thrombus burden that is present all the way through. And this is, multiple overlapping images combined together to show you, and this is being done at a higher speed than usual, just so we can show you what we did. And we use higher frequency when we treat above the knee versus when we treat below the knee. And we take our time getting through this, even though this is being sped higher speed imaging, but still we're going very slow. And if you want to get good results with using any form of atherectomy, you've got to take your time and let the atherectomy device do what it's supposed to do. And that is give you the best possible results. And the best way to get the best possible results is by going slow and let the atherectomy device do its job. So we took this 1.5 laser atherectomy all the way down to the plantar aspect, and then and let it basically ablate the emboli that is this embolized distally. Remember, we have the wire looped into the medial plantar artery. So we started with balloon angioplasty from distal to proximal, and we usually start with the 2.5 in the plantar, and then use that as much as we can, and then go to 3.5. We call that sequential balloon angioplasty, and that tend to give us a very good results at the end of the day. The inflation is slow, and we tend to stay for 2 minutes. And don't try to cut corners, because cutting corners is not going to help you. As it is, based on the Bowman's paper, balloon angioplasty alone caused significant recoil in tibial arteries within 15 minutes. So if you can actually use the atherectomy slowly like we did, plus prolonged balloon inflation with a balloon size that is probably 1.1 to 1, is going to be the best option. And this is a great result here. You can see that the artery, posterior tibial artery, has gotten significantly bigger in size. And play that again for you. That's because we did sequential angioplasty, starting with a 2.5 and ending with a 4.0 proximally. So the next step is we have to address the popliteal. Remember, in the IVUS, we saw disease into the P2 segments, but there was nothing going on with the P3 segment of the popliteal. So we didn't want to mess with the P3 segments. And now we're doing another sequential balloon angioplasty. And again, based on the IVUS and the amount of plaque that we saw, we have to do this very slow and prolonged in hopes that we can control and condense the plaque. Well, this image is not surprising now. This is post-balloon angioplasty. And you can see that the organized thrombi in the plaque is going to give you this sort of uneasy look of sort of dissected organized plaque. And look at the narrowing that is present here, dissections in this area. And this is where everything starts. So, and the flow is not the healthiest. So the question here is, what do we do with this? So as I go to the next slide, hopefully you're thinking about what would you do next for this patient. Here you go. Well, best thing to do is repeat the IVUS, because, you know, if the IVUS is repeated and it shows that there is a significant reduction in the plaque and the flow is normal, then you just move on. But what happened here is there is actually plaque, there's a reduction in the plaque, reduction in the thrombi. Remember, this was nearly occluded here with thrombus, organized thrombus, but it's reduced significantly. But look at the mobile residual organized thrombi. Now we're going to mark this again, because we want to treat areas only, areas that requires therapy. And in this case here, we would like to trap any problems. Notice here the amount of unorganized ruptured plaque. This is a area waiting for disasters to happen, because the blood is going to come here and swirl. And if it does swirl, platelets may get activated and thrombi may form and embolization can happen. So this cannot be left alone. Something should be done to it. There's a lot of different things that can be done, so we can think about that as we go. But the vessel is very well prepped, but not too prepped to the point that you can just walk away from it. And you can still see high plaque and organized thrombus present. So how do we control this? What would we do now to ensure that none of this will embolize distally? Let's go back and check the P3 segment, making sure that nothing's changed in it before we do anything else. So nothing has changed except the size of it got bigger. So because of that, we elected to deploy a superior stent. And let me play that for you. The superior stent is an art when you deploy it, and based on the trials that were done with it. If you deploy it properly, it should have good long-term outcomes. And as you can imagine here, we pre-dilated this area again with a 7O balloon to deploy a 6.5 millimeter stent. And notice how the geometric ergometry of the stent is very symmetrical. And based on published data, this is the kind of results of stent deployment that will give you the best patency in the long term. Now, you got to take your time, and this is the marker that we have put in place. So the stent was deployed to the marker and beyond, and that is exactly what we wanted. We wanted a good inflow into it and good outflow distally. So we covered all the area that had high plaque burden that we've seen. Here's the final results, and notice the brisk flow in it. And look at the brisk flow in the tibial arteries now, significantly better. The PT looks much bigger because it was treated. And the flow in the posterior circulation is now completely intact, and the pedal loop is now shown that is intact. But the narrowing of the AT in the perineal artery is consistent with disease. But at this point, with this kind of flow to the foot, most likely this patient's symptoms would resolve, and we decided to stop at this point. Again, ultrasound-guided access was done to ensure an exit strategy. Because of the confidence in the access under ultrasound, we decided to get a closure device under ultrasound as well. Here's the plates being deployed and pulled back against the vessel wall, and the close was deployed. And this is for safety measures and success of the deployment of the device and getting good hemostasis. Thank you for listening, and I hope this was a good case to share with you on how to address a high-grade stenosis due to organized thrombus plus plaque presence in a long segment of the SFA popliteal all the way down to the posterior tibial artery. This is Dr. Mustapha, and thank you for the opportunity.